Recording in progress.
Right. Good evening, everybody. Am I audible?
Yes, sir.
Okay.
Yes, sir.
Good. So, welcome to the evening session of the interactive clinical discussion or interactive clinical scenarios. This is just what you face every day in the outpatients. And this is just to take you down the path of the thought process that goes through your mind when you make a diagnosis. I want you to be active and alert and talk. And I'm disappointed that only 2 volunteers, great difficulty we found. And because there's not a final exam, nobody is going to get marks or nobody is going to fail. But still, people are hesitant to talk. You have to break out of your inhibitions and talk. It's important for exam, and it's also important for your later on career. Okay? So here we are, you're sitting in the outpatient, and a young man comes to your outpatient. Okay, are you all with me now? Can you see my slide?
Yes, sir.
Yes, okay. So everybody should read it, but especially Anushri and Amaya. 18-year-old boy, he is dyspneic, class 2 for the last 10 years. No recent deterioration, no paroxysmal nocturnal dyspnea, no edema, no abdominal distension, no giddiness or syncope. That's the history. He is cyanosed, grade 2 clubbing, central cyanosis obviously. A JVP prominent A wave, no edema or hepatomegaly. No sign of heart failure. The apical impulse was left intercostal space outside the midclavicular line. There is a parasternal heave, and the second sound was palpable, the usual space, second space. The second sound was normally split in respiration. The second sound, the pulmonary component was accentuated, and a short ejection systolic murmur grade 2 at the pulmonary area. Now, these are the physical findings. Now, when I finished with this slide, you're welcome to ask me any more information that you want, okay? So that was the history in short, and that is this is an outpatient case. So, you don't have a very detailed history. When you examined, you found the pulse oximetry was 84%, and he brought some reports with him, 17.6 hemoglobin. His ECG showed sinus rhythm, normal axis, and right ventricular hypertrophy. He also carried a prescription for furosemide 20 milligrams a day. So that's it. That's what he has. So do you want to ask me any more questions about him? I can give you. But you shouldn't take too much time because then we will run out of time.
Sir, what about respiratory examination, sir?
Respiratory examination was essentially normal. There was no repetition. There was no rhonchi. Air entry was equal on both sides. Yes. Yes, that's a good question. Any other question you want to ask? Anybody can ask actually, but you two are the main volunteers. Any other data you want? If you do not have any more information that you need, I'll move on to the next slide.
Sir, any history of previous admission?
There must be admission. Okay. Right. You can always ask me later on also. If you have any, you want to come back to physical examination and ask me some question, we are welcome to do it. Okay, later on also. Right. Shall I go on to the next one?
Yes.
Okay. Okay. You didn't. I told you what what's your clinical impression from this?
Doc, we have the message in chat box also. Answers in chat box also.
Yeah. Okay. Yes. Any impressions on this, on physical? Because we always form a working diagnosis on clinical examination, and then only we go on to the investigations. So what does these physical science and history tell you? Come on, quick. OPD don't have much time, no? You may have to see 15 cases in a matter of 2 hours, 3 hours. Come on, this is cyanotic patient. At least start with that. That's obvious, no?
Yes, a cyanotic
yes, central cyanosis.
congenital heart disease, sir.
Okay. Right, congenital heart disease because there is central cyanosis. Okay. What else? What other conclusions can you draw from physical science?
Sir, I can draw that there is pulmonary hypertension, sir.
Very good. Yeah. Why did it take so long to tell? The A wave is prominent in the jugular vein.
A wave is prominent. There is loud P2 and palpable diastolic shock is also there, sir.
Yeah, palpable second sound is there, and that. So and
what is the ejection systolic murmur grade 2/6.
So what? So combination of pulmonary hypertension and cyanosis in congenital heart disease. What is the likely diagnosis?
Sir, TOF.
At 18-year-old, TOF produces loud P2?
No, sir.
Then that's the wrong answer, no?
Yeah.
Tetralogy fellow will not produce a loud P2.
No, sir.
Does it produce a normally split second sound?
No, sir.
Then?
Mostly single S2 it produces, sir.
What's the congenital heart disease? Pulmonary hypertension and cyanosis. Anybody can answer. No? Quick pulmonary hypertension cause right to left shunt and cyanosis.
VSD with severe VSD with Eisenmenger.
So why are it taking so long? Pulmonary hypertension and cyanosis. Most common cause of the 18 years is Eisenmenger syndrome. Yes, it can be it may not be VSD, it may be ASD, it may be
PDA with Eisenmenger syndrome.
It may be ASD, it may be VSD, it may be PDA. How do you know?
Sir, the S2, sir.
Is there any clue in the physical sign whether it can be ASD or VSD or PDA?
Normal split S2.
The normal split S2 goes with which condition? No, these are all pediatric questions. These are not pediatric cardiology questions.
Sir.
What is the second sound of VSD Eisenmenger like?
Single, sir.
Single. Okay. So why don't you exclude VSD at least?
Yes, sir.
Okay. What is the second sound of ASD like when they develop pulmonary hypertension?
It is narrow and fixed, sir.
It's not narrow and split. It remains wide split. It remains in ASD. The second sound remains wide split. And what is the second sound like in the patent ductus arteriosus when they develop Eisenmenger? You had normal split, you had wide split, you had single second sound. What is the third one possible? Normal split.
Normal split.
So patent ductus arteriosus. The second sound is a key to all diagnosis of pulmonary hypertension in Eisenmenger syndrome. So ASD Eisenmenger has wide split second sound. VSD Eisenmenger generally has a single second sound, and patent ductus arteriosus typically has normally split second sound when they develop pulmonary hypertension. So among the Eisenmenger syndrome, well, we won't consider complex diseases, because complex diseases anyway you can't diagnose clinically. Let us talk of simple lesions. Out of these three, which one do you think is most likely here?
The PDA with Eisenmenger.
PDA with Eisenmenger. Okay. Now, do you want to ask any clinical question? People are answering in the chat box. I don't know why they don't want to come forward and answer. Varun, you are writing in the chat box, but you don't want to. Kasim is answering in the chat box. Why can't you come forward as a volunteer and unmute yourself? So it takes time to go through your chat box and answer one by one. Okay. So, do you want any information in the physical science, or when it comes to PDA with Eisenmenger?
Differential cyanosis, sir.
So unless you ask me, how will I tell you? Did you ask for it? I have told you central cyanosis. You never asked me whether it is differential cyanosis or not.
Yes, sir.
Okay, now I will tell you the saturation in the upper and lower limb are equal. There is no differential cyanosis. Okay?
Okay, sir.
Okay. So now what? And there's something unusual in the physical findings?
Ejection systolic murmur at pulmonary.
Well, that's not unusual. Any pulmonary hypertension can have ejection systolic murmur. What is unusual in the physical science? Can anybody tell me? One
Cardiomegaly.
Cardiomegaly. Well, cardiomegaly, yes. Anything more in cardiomegaly? The apical impulse is downward and outwards.
Yeah,
Sixth intercostal space outside midclavicular line. Does that happen in right ventricular hypertrophy?
No, sir. It was only outwards, sir.
Yeah. So there's something unusual. For Eisenmenger, with simple pulmonary hypertension, the left ventricle seems to have enlarged. Sixth intercostal, one center space lower down. So that's something unusual. I don't know what it means at this stage, but we'll keep it in mind. But unless you ask me, I won't tell you all this. There's no differential cyanosis. The LV is probably enlarged along with the RV, maybe. But RV I can explain by pulmonary hypertension. The LV I don't know how to explain. Let's see. Okay. So now what do you want to do? What do you want to do?
Chest X-ray, sir.
Okay. Well, chest X-ray, ECG, echo, everybody wants. No? Yeah. So don't take much time on that. ECG I already told you, right ventricular hypertrophy.
Normal axis.
Okay, that's the X-ray. Come on, quick. Your diagnosis clinically is Eisenmenger syndrome. Now go ahead. Come on, quick. Mild cardiomegaly is there.
Yes, sir.
Apex
Pulmonary
is
bay is also dilated.
Dilated.
Right pulmonary artery looks dilated, sir.
Right pulmonary artery is
Peripheral
dilated.
pruning is also there, suggestive of pulmonary hypertension.
Pruning, yes, it's suggestive of pulmonary hypertension. I agree. So you are happy with that? Does it fit your diagnosis of PDA pulmonary hypertension? In addition, what do you expect in PDA pulmonary hypertension? You expect what other features you get in PDA pulmonary hypertension? You expect the aorta to be dilated.
Aorta dilation.
Is aorta dilated?
No, sir.
Not particularly, but
not much, sir.
Yes, it is. But maybe slightly prominent. Slightly prominent, but not enough to rule out PDA. But PDA is there. Okay. Is there anything else you want to tell me in the X-ray? Okay. So, do you see any end-on vessels? No, to suggest plethora.
Yes, sir. End-on vessels, sir. on the right.
You see some globular
midzone.
shadows here. You see some globular shadows here, isn't it? Yeah, maybe they are end on vessels.
Almost
I
3
don't
to
know.
4 on the
At this
right
stage,
mid-lung zone and 1 or 2
Okay.
on the left side,
Okay.
suggesting
So-
pulmonary plethora.
Okay. So you think it is consistent with your diagnosis of
PDA with Eisenmenger.
PDA. Yeah. Okay. I don't know. Maybe you're right. I don't know. Let's see. So now what do you want to do? You want to see the echo.
2D
He brought an echo with him. So that's the report I'm to, because this is OPD, you remember.
Yes, sir.
So this is the report. Normal segmental anatomy, no atrial enlargement, no right atrial enlargement, mild left atrial enlargement, normal LV dimensions, dilated main pulmonary artery and branch RPA and LPA. The IAS and IVS were intact. The interventricular septum was flat, so that suggestive of pulmonary hypertension. Normal left-sided arch. No, they did not find a PDA. At least they could not visualize a PDA. Doppler estimated RV pressure 75 millimeters of mercury. So, what is the diagnosis now? Oh, you got X-ray, ECG, echo. What more do you want? And hemoglobin. Come on, quick. We have to be fast. Otherwise, I have one long case and 2-3 short cases. If you finish in time, you have to. Yes, anybody else also. No, anybody can know. Most of the time, OPD, this all is available. No, X-ray, ECG, and echo. So you have to make a clinical diagnosis now. Come on. Amaya, you have any thoughts? She says we PDA Eisenmenger, but I find it a little unusual that there is no differential cyanosis. But is differential cyanosis always a must in PDA Eisenmenger? Anushree, is differential cyanosis always present in Eisenmenger syndrome?
Sir, if there's bidirectional shunt.
Well, in the beginning, differential sinus is always there because the desaturated blood going from the PDA to the aorta goes straight into the descending aorta. But later on, at a later date, cyanosis becomes more uniform. But at any stage, the lower limb always shows more clubbing and more desaturation than the upper limb. Okay. So this patient had equal saturation, the upper and lower. So anyway, that's unusual, but you are diagnosing PDA PAH. So any more clinical information you need? If you want, I'll tell you now. Otherwise, you have to tell me what is your next plan. Because as a consultant in the OPD, you need at the end of ECG, echo and X-ray, you need to have a provisional diagnosis and you need to have a plan. What is the next step?
Cath study, sir.
You want to do cath? Yeah, right. You said cath? I didn't hear you.
Yes, sir. Yes,
okay,
sir.
Good. So you are suggesting get admitted, I will do cath. Then he remembered, oh, I have one more report with me in my pocket. Let me show it to you. Oh, you are lucky. He already had a cath done.
Already has a cath.
So now only he is showing his report. Okay, now you wanted cath, I given you cath data. What does it show?
Sir, the RV systolic pressure is very much raised, sir, 68. Pulmonary pressures also, sir, systolic of 70. And
the best way of describing this, when you want to talk like a consultant, you shouldn't say RV pressure 68, PA pressure 68 and all. You look at the values and say the patient has pulmonary hypertension. And because PA systolic is 70 and mean pressure is above 40,
44.
It's severe.
Severe.
You say the patient has
pH.
severe pulmonary hypertension. That is a professional way of describing it, not RV pressure is 68, PA pressure is 70. That's not the way to describe. So there is severe pulmonary hypertension. What else?
And the saturation on the left side.
What does it show?
Indicating cyanosis, sir.
Indicating cyanosis. Okay, good. So there is desaturation. Okay.
Left side. Yes, sir.
Anything unusual in this cath data? Is anybody among you third years? Out of 10, 11 participants, is there any third years in this? Or no? No, nobody's answering.
Aortic saturation is less than LV, just by 2%.
Less than LV, that's okay. 2% difference is not there. But what is unusual about this data? See, as a consultant, you should always see whether the data is fitting your diagnosis. Your diagnosis is PDA-PAH, isn't it?
Yes, sir.
Okay. So what is unusual about this saturation data? I'm giving you a big hint now. What is unusual about this saturation data? Anybody can answer.
Sir, aortic saturation should have been more on lower side had it been.
Aortic saturation should have been more what? No, I didn't get it. Okay. Somebody has put something in the chat box, but unfortunately they don't want to talk. LA is decided. Varun, I won't give you any credit for writing the answer. Why don't you talk?
Doc is unable to speak. His mic is not working.
Okay. Okay. So yeah, Anushri, you heard that the unusual finding about that the cath data is telling is that LA is desaturated.
Yes,
you know what he means? In PDA, where is the desaturation? Where is it happening?
So step down happens from pulmonary artery to aorta level. Sir.
Which aorta? Which level? Which aorta?
It is the descending thoracic aorta.
Right.
Sir.
Now, where is the desaturation in this case?
LA, sir. There is step down at.
Then how can it be? How can it be PDA right to left hand?
Yes, sir.
No, you should see this is what is clinical thinking all about. So it's just not compatible with PDA-PAH, no? What causes the LA desaturation?
LA desaturation occurs in ASD Eisenmenger, sir.
ASD Eisenmenger. What? So does this patient have an ASD?
No, sir.
No. In fact, they have written intact IAS. So that
intact
means maybe there is no PF also. So how did the LA get desaturated?
Pulmonary AV fistula.
No, I don't want the diagnosis. I asked, my question is, how did he get LA desaturation? He doesn't have ASD or PFO. So how did he get LA desaturation?
PFO.
Yeah, you said pulmonary fistula, but you answered my question. How did he get LA desaturation?
So that means the blood draining from pulmonary veins into LA is only.
Yes. So pulmonary vein is desaturated.
Completely saturated.
Possibly. Possibly pulmonary vein is desaturated, isn't it?
Yes.
So that's the answer I want. This oximetry shows severe pulmonary arterial hypertension, but oximetry is somewhat unusual for Eisenmenger. There is desaturation in the LA. Unlike not in the aorta as we expected, and echo did not show intra-atrial communication. So we do not know whether this desaturation or right to left shunt occurred in the atrium or it occurred in the pulmonary vein.
Pulmonary level.
Okay. So now, what are the causes of? Let us look at the causes of pulmonary vein desaturation. What are the causes of pulmonary vein desaturation?
The patient is only hypoxic, sir. Second, there will be pulmonary AV fistula, sir.
What do you mean hypoxic?
Because of...
Or in other words, suppose you are doing this cath, what would you do now? Let me ask the question in a different way. You found this oximetry data. Now what will you do? What will you do now?
Sir, we will give him supplemental oxygen and again...
No. You will enter the pulmonary vein and take a sample.
Okay.
You want to check the pulmonary vein saturation, no?
Yes, sir.
So pulmonary vein saturation, if pulmonary vein saturation is 100%, then you know that the right to left shunt is at the atrial level. If the pulmonary vein sample is also desaturated, then we know that the cause of cyanosis is not in the heart.
At the level of pulmonary.
At the level of lung.
Pulmonary circuit.
At the level of pulmonary vein, yes. So, what is your plan now?
To take pulmonary venous sample and
vein
oximetry.
Okay. Now, this cath has already been done. So, what I did was I called the doctor who did cath and asked him, did you enter the pulmonary vein? Did you take a saturation? Okay.
Yes, sir.
And this is what he told me.
It is also less, sir.
Okay. So now what is the diagnosis? Pulmonary hypertension with desaturation in the lung. Right?
Yes, sir.
Okay. Now what causes pulmonary vein desaturation? You said hypoxia. So you have to explain how what causes hypoxia is not a good term. You must use a better term. That's not a very scientific term for explain desaturation. What is the actual term to be used when you want to explain pulmonary vein desaturation due to inadequate oxygenation? Inadequate oxygenation is impaired oxygen exchange or impaired ventilation. Impaired ventilation can be excessive sedation, general anesthesia, collapse of a lung, central neurogenic apnea. It can be lung disease, pneumonia, collapse, pneumothorax, any number of conditions, impaired oxygenation. Am I right?
Yes, sir.
Okay. And other group of condition which can cause pulmonary vein desaturation is what you mentioned, a right to left
fistula, sir.
Yes, a right to left. That's a see. Always talk in terms of physiology. We have not made an anatomical diagnosis yet.
No, sir.
What is the physiology? It's a right to left shunt at the pulmonary vein level.
Yes, sir.
A right to left shunt at the pulmonary vein level is a pulmonary arteriovenous fistula. These are the two possibilities. Am I right?
Yes, sir.
Okay. So now what?
Sir, I will require HRCT thorax to see the lung fields.
Oh, he is a very poor man. He has already spent all his money on cath. You want to send him for HRCT? He doesn't have the money. Will you pay for it?
Okay, sir.
And he's come in the OPD from the village. You have to give him an answer now. The important thing, how will you rule out inadequate ventilation and lung conditions and all? The simplest way to look at the X-ray again, carefully.
Yes, sir.
This patient is an adult patient. catheterization would have been done in the awake patient. Nobody would have used general anesthesia. Am I right?
Yes, sir. Yes, sir.
And nobody would have used deep sedation.
Yeah.
And so we need to look at the X-ray again carefully. Okay, there's no collapse, there's no consolidation, there's no area of the lung which is not ventilated, and I can see blood vessels in all segments of the lung. So at least no obvious oxygenation defect. Okay.
Yes, sir.
Now with the point of view of right to left hand at the pulmonary vein level, do you want to see the X-ray again? See, always clinical diagnosis is a matter of going back and forth. Whenever you get some evidence and you have some doubt, you go back to physical science, you go back to the X-ray, you go back to the echo. So now that we have some new evidence, you have to look at the X-ray again more critically. Anybody comment on the X-ray? Anything new in the X-ray? VQ scan, Varun, they're all very high-tech cardiologists. Please talk simple things which this patient can afford. Anybody find anything unusual in this X-ray? You described many end-on vessels, no?
Yes, sir.
But this
It
patient
was a
has
part of pulmonary plethora, sir.
Yes, but we don't have a pulmonary plethora in this condition. We are talking of pulmonary vein desaturation.
May I answer, sir?
Who is it?
Sir Sulagna here.
Now, why didn't you answer all this time? Suddenly you are answering. You are most welcome now also. But
No, sir, actually, I can't hear your voice. Like it is breaking last 2 minutes.
You are most welcome to answer. Keep your mic on and answer. Are you second year or third year?
On this X-ray, if I find anything unusual,
yes.
Sir, the left upper lobe seems less vascular than the right.
No, Sulagna, that I don't agree. The upper zones are always less vascular than the lower zone. And I don't think any of the difference between the right and left. I don't think that's the answer. See, concentrate on the round shadow which we called end-on vessels. Many rounded shadows here. Okay. Now that we know that without PDA, now PDA looks unlikely, but pulmonary vein is even here. There are round blotches here. Can you see this?
Yes, sir.
Yes. So
this indicates that pulmonary plethora, sir. Could be secondary to pulmonary veno-occlusive disease or something like that, sir.
Pulmonary plethora means increased pulmonary blood flow, a shunt lesion. Does this patient have a shunt lesion? Like ASD, VSD, PDA?
No,
Does
sir.
he have a shunt lesion?
We have ruled it out, sir.
No. So then what do you think these rounded shadows are? I'm giving you a direct hint and still you're not taking it. What causes pulmonary vein desaturation and causes rounded opacities in the lung? Multiple AV fistulas.
Okay, sir.
See, what we thought was earlier end-on vessel could possibly be the AVM.
AVM, okay.
Here. Can you see multiple spherical shadows here and there? Yeah, that possibility, we should keep it. See, you should be very critical. Now that we have ruled out a shunt lesion, we have to explain this rounded shadow. And because he has got evidence of a pulmonary venous right to left shunting, there is a strong possibility that these round shadows actually represent pulmonary AV malformation. We should keep that in mind. Am I right?
Yes, sir.
Yes or no?
Yes, sir.
Okay. If anybody disagrees, say so. Okay. So now I'm going to. So what is the next step?
Bubble contrast.
Bubble contrast. What do you do, bubble contrast? How do you
Sir,
do?
we give agitated saline through the peripheral venous system, sir. And then we look for whether we get those bubbles more than 20 on the left side of the heart after 5 cycles or 5 cardiac cycles, sir. Then it supports the diagnosis of pulmonary AV fistula, sir.
Okay. And if it is endocardiac shunt?
If it is ASD or a PFO causing a right to left shunt, then within 3 cycles only, sir, we will be able to see the bubbles on the left.
You said peripheral vein. Which peripheral vein are you talking of? Which peripheral
sir,
vein?
right cubital, sir.
Okay, so that's not a peripheral vein. No? The answer is I would like to use a large vein possible with a large size cannula so that I can inject rapidly. Don't say peripheral vein. I would get a large cannula into a large vein as close to as possible to the SVC. The closer you are to SVC, the better it is, because then the contrast won't get diluted. Okay, don't say peripheral vein.
Okay, sir.
Okay, so you wanted, so bubble contrast is a cheap test. I can do it in the outpatient. So we were able to do it in the outpatient. So this is what it shows.
It is positive, sir.
I don't know what is positive.
I'm able to see more than 20 bubbles.
20 bubbles? So right to left shunt at what level?
Sir, it is within 3 cardiac cycles.
I'll start from the beginning if you want. Okay, this is the beginning.
Sir, I am able to see a shunt at the level of atria, sir. The bubbles are coming from RA to LA and then gushing into the LV, sir.
Okay. Okay. Now, be careful before you say that, because you had pulmonary vein desaturation and now you're telling me there's a right to left shunt at the atrial level. So, is it immediate appearance from RA to LA or is it delayed appearance?
It is delayed, sir. 3 beats.
Then why are you saying atrial shunt? Can't you see now the RA is filled and LA is
it is coming from pulmonary.
It's coming quite late, isn't it?
Yeah.
I'll show you again. Okay, now RA and RV has opacified already.
Yes, sir.
Until L and LV are clear.
Clear only, sir.
Still not appeared. Still not appeared. Now only they are starting to appear.
So the origin is not so clear, but
so it is delayed. It is delayed appearance of contrast in the LA. Therefore, it must be suggestive of AV
pulmonary
malformations in the lung. Okay.
Or pulmonary malformations.
Okay. Now what? Next. What is the next step? Come on, quick. We're running out of time. What do you want to do next? You should have a plan. Anybody can answer. Come on. Your diagnosed pulmonary AV fistula is sinus and polycythemic. What do you want to do? And he's got severe pulmonary hypertension.
CT pulmonary angio, sir.
CT pulmonary angio. Why do you want to do CT pulmonary angio? Yeah, good answer, but why?
To locate the number of fistulas and the biggest size or...
Good. Okay. So that means all fistulae are not the same. There are different types of fistulae. No, pulmonary AV fistula is not one type. There are many types of pulmonary fistula. Do you know how many types there are? Does anybody know? Classification of pulmonary AV fistula? Okay, I'll tell you. Okay, this was a classification given long back. So type 1 is multiple small fistulae without an aneurysm. The second one is multiple or single fistulae with small aneurysm. The third one is large aneurysms, anomalous vein. Fourth one is aneurysm with a systemic arterial communication. And fifth one is multiple fistulae with anomalous vein. Okay. So why is this typing important? Of course, another type of classification is nowadays used is simple. Simple means a single feeding artery. Complex is more than one feeding artery. And diffuse is multiple small all over the lung. Right?
Yes.
Now the importance is that treatment will differ if it is simple or complex or diffuse. Okay? Which one do you think this one is?
Sir, it looks like diffuse, sir.
Multiple diffuse with aneurysm.
Yeah.
Right? This variety. So just to tell you the different types, you can have a solitary fistula in one lower lobe. It can be a large aneurysm as shown here. This is not this patient. These are just a theoretical. And then these are the small rounded shadows like the one we saw in our patient. Multiple small ones scattered all over the lung. And then finally here is a multiple microscopic type. We don't see anything in the lung. But still there are multiple microscopic fistulae. So yes, CT angio can tell you the number of fistulae and which type of fistulae. And yes, that's a good investigation to do in the beginning. But before that, is pulmonary hypertension a common feature of pulmonary AV fistula? You didn't tell anything about it. Why is this fellow having severe pulmonary hypertension? The pulmonary artery pressure is only 30. It drains into the pulmonary vein. Why is she having severe pulmonary hypertension?
Sir,
okay, before that, any other information? 1 second. Before that, any other information do you want?
Sir, is there orthodeoxia associated with pulmonary fistula?
No, orthodeoxia, I think we are getting into the wrong territory now. Any more information regarding pulmonary AV fistula? You know of any clinical syndrome which causes pulmonary AV fistula? Have you heard of hereditary hemorrhagic telangiectasia?
Osler-Weber-Rendau syndrome.
Osler-Rendau-Weber syndrome. So, don't you want to go back to physical examination and look for some signs of Osler-Rendau-Weber disease? What would you look for? Varun, you're right. Varun, you're right. I agree. I'll come to that. You must look for many
Spider-Levi telangiectasias.
You should look for family history, autosomal dominant. At least one more first degree relative will be affected.
Okay.
History of, they would have AV malformation multiple locations in the body. In the nose from epistaxis, GI bleeds, in the mucosa of the mouth, in the skin, in the nail bed. In fact, many organs in the body might have it, even including the brain, cerebellum. Okay? At least you should go back to the physical history and ask me whether he had epistaxis, whether he had bleeding from somewhere, did he have any mucosal lesions, any AV malformation visible under the skin. See, in real life clinical management as well as the examination, you should have always this back and forth correlation. Okay, so this is one thing that you have to keep in mind, and I'll tell you none of this is there. This boy doesn't have a history, no epistaxis, no mucosal telangiectasia, skin, nail bed, and as far I could see, no other AV malformation in the body. Okay, what's the other condition? Anything else you want in the clinical examination? Anybody? There's something unusual in this case. Otherwise, it's straightforward pulmonary AVM. You go on a different line of management. But because there is unusual thing, I am talking to you. What is unusual in this case? Anybody? Come on, guys. Think. I gave you a hint earlier.
LV cardiomegaly, sir.
Why should a patient of pulmonary AV malformation have pulmonary hypertension? Is that common? Have I mentioned pulmonary hypertension anywhere in hereditary hemorrhagic telangiectasia? What is the condition which causes pulmonary hypertension and pulmonary AV malformation? It's one of the correctable causes of pulmonary hypertension. Portocaval shunt. Haven't you heard of it? Have you heard of it? Yes, Anushree, have you heard of it?
Yes, sir.
Then why didn't you say that? That's one of the, it's a rare combination of pulmonary hypertension and pulmonary AV malformation. There are very few conditions which causes cyanotic AV malformation and see, all pulmonary hypertension have microscopic AV communication, but they don't cause cyanosis. Portocaval shunt, or also called hepatopulmonary syndrome. Portopulmonary syndrome. Portocaval shunt. Keep in mind that can cause pulmonary hypertension, portal hypertension, and it can cause AV malformation in the lung. Cirrhosis liver can cause AV malformation in the lung. Don't you know?
Yes, sir. Type 1 pulmonary hypertension, sir. Portopulmonary. So, and these patients can have that orthodeoxia, sir, and platypnea, which is one clinical phenomenon.
Now, portocaval shunt. What is the next step you want to do?
Portal Doppler.
Sorry, I didn't hear that. Yeah, Bhavi Modi, you said something malformation. What do you want to do as the next step? Bhavi, are you there? Yeah, what is your next step?
USG abdomen and portal Doppler, sir.
Okay, good. Who said that?
Dr. Anushree.
Anushree, okay. Right, absolutely right. I want to do an abdominal ultrasound to see the portal vein and the hepatic veins. Right?
Yes, sir.
Okay, so here you are. The portal vein, the abdominal ultrasound is there on the left side and the color Doppler is there on the right side. I know we are not experts in abdominal ultrasound and I don't expect you to know all that. But at least, can you see some large venous channels? Is this normal or abnormal? You must have seen some abdominal when you look for the subcostal echo. You've seen subcostal window?
Yeah, we have seen subcostal, but
okay. Is this normal?
This more dilated.
Yes. So whatever venous structure is there is usually dilated, isn't it?
Yes.
Now, the largest venous structure in the abdomen is always the IVC. So this must be the IVC. The blue must be the IVC going towards the heart here. Okay?
Yes,
right? IVC is dilated. And this is the liver. The liver is going between the between the left lobe and the right lobe, there are IVC is going there. And there's some big vein coming and joining the IVC. Can't you see this? Almost as big as the IVC. Renal veins, superior mesenteric veins, etc. will not be that big, no? So there's a large vein joining the portal vein, joining the IVC. So we know that there is some abnormal communication here. So you can safely bet that this must be probably a portal vein.
Hepatic vein, sir, or portal vein?
Well, do you think hepatic vein will be as large as the IVC?
No, sir.
Then? Okay, anyway, then at least you know it is abnormal enough to call the radiologist and ask him to have a look. Am I right?
Yes, sir.
Yes. Then you need to get a professional ultrasound examination of the abdomen. And he will tell you that this is a large dilated portal vein, which is draining somehow into the IVC. Is that normal? Does the portal vein communicate with IVC?
No, sir.
Where does it drain to?
Sir, portal veins from the small capillary network of the liver, which then combines to form hepatic vein, which then joins the IVC, sir.
Yes. So the portal vein blood can never enter the caval system unless it goes into the liver and passes through the liver parenchyma, normally. But when there is an abnormal communication, the portal vein blood can drain into the vena cava. So what happens is blood returning from the GI tract is going into the systemic circulation.
Recording in progress.
Without being filtered without being filtered in the liver. Am I right?
Yes, sir.
Yes. So why does it cause cyanosis then? How can this cause cyanosis and pulmonary hypertension?
Because of the vasoactive substances that directly get shunted to pulmonary circulation, sir, causes pulmonary remodeling and pulmonary hypertension.
Very good. There are metabolites coming from the gut. We exactly do not know the nature of the metabolite. They are believed to be some peptides coming from the GI tract. Normally, they get filtered off by the liver. Whenever the portal blood bypasses the liver, they can give rise to pulmonary AV malformation as well as they can give rise to pulmonary hypertension. That is why in portocaval congenital anomaly, they can have pulmonary hypertension, pulmonary AVM. Cirrhosis of liver sometimes has the same thing. And there are other conditions of portopulmonary syndrome, where liver disease is associated with pulmonary hypertension. Okay? So this boy has a large congenital communication between the portal vein and the inferior vena cava.
Yes, sir.
So now we have made the diagnosis in the OPD itself. Okay, now this is just to teach you. I am not, this is not from this patient. The CT angio will show that there are multiple small saccular aneurysmal masses in the lung, which are opacifying with contrast. And these represent multiple AV malformation with aneurysm in the lung. Right?
Yes, sir.
When you do an abdominal venous IVC angiogram, you find the IVC is a posterior structure lying on the spine here. And there's a large vein coming from, this is the direction of the superior mesenteric vein. The portal vein is a combination of superior mesenteric vein and
Splenic vein.
And this portal vein, instead of breaking up into capillaries inside the liver, it's opening into the IVC. So this represents the fistula, star. The same thing is represented in axial section, the IVC here and the dilated portal vein here. Okay, and this represents the volume reconstruction. This is the splenic vein coming here. This is the superior mesenteric vein coming here. Both together form the portal vein, and the portal vein has a communication of the IVC. Now, this is not this patient, this is a similar patient. Okay. Now, in this patient, suppose I were to do an IVC angiogram, this is what it would look like. The catheter has gone from the IVC. Normally, you should go directly IVC into the right atrium here. But here it has gone out of the IVC into another venous structure. And that venous structure has got some communication with the liver, but these hepatic sinusoids are very few and very small in size. Now, when I run the angio, you will see that contrast is spilling over into portal vein and the superior mesenteric vein here. Keep watching. Okay, now this catheter has come from IVC, but this is not the IVC, this is the superior mesenteric vein.
Okay. That is okay.
That's the portal vein, and that's the portocaval shunt. Okay?
Okay, sir.
So there are different types of portocaval shunt. This is a normal drainage. IVC does not have any communication with the portal vein. IVC gets the hepatic veins and goes into the RA here. This is normal. One type is the intrahepatic portocaval shunt. That is either the right hepatic vein or the left hepatic, right portal vein or the left branch of the portal vein communicates with the hepatic vein inside the liver. So this is the intrahepatic variety of portocaval shunt, also known as Abernathy malformation, Abernathy. Or they can be extrahepatic. The splenic vein and the superior mesenteric vein can drain separately. They can form a combined anastomosis. That is what we see in this patient. And the third one, it can be a side-to-side connection like this. It can be end to side or side to side. Okay? So these are the different types of Abernathy malformation. Now I want you to go back and read different types and how to manage each one of them. I don't want to go into the details. Okay?
Okay, sir.
So the final diagnosis is congenital portocaval shunt, pulmonary AV malformation, and severe pulmonary arterial hypertension. So we have arrived at the entire diagnosis in the outpatient department. That's what I said, clinical thinking and analysis. Okay. This is the accepted classification of pulmonary arterial hypertension. And you will find that the pulmonary venous and hemangial AV malformation all appear in class 1, the group 1 cause of pulmonary hypertension, along with other idiopathic and other varieties. But pulmonary vein anomalies and hemangioma malformation appear in group 1. Okay? Right. Do we have time for one more case, Kavita? Just a short case.
Sure, Doc. Please. Yes.
Okay.
Right. Tanushree, okay for you, Dr. Tanushree?
Yes, sir. Yes,
Okay.
ma'am.
So thank you.
Right. Now, this is a couple of short cases we have. However much time we have, I will cover. Now, come on, we should be quick. You are sitting in the outpatient department, a lady who has got repaired CHD. I think it was pulmonary ASD repaired. She had severe PAH even before operation and high PVR. And after operation, also the pulmonary hypertension is persisting. She is in class 2. She is not in no syncopal episode. Dual anti-PAH treatment, bosentan and sildenafil. And we generally advise them not to become pregnant. And you know why? Why we don't advise pregnancy?
Sir, poor fetal outcomes, sir, with severe pH.
Okay. And poor?
Maternal outcomes also, sir.
Okay. So generally pregnancy is not advisable. She's now 22, but although we advise, she became pregnant. Indian ladies, they badly want a child, they became pregnant. And now she has come to you. The question is, how are you going to handle this? This is a clinical problem. What are you going to tell them? How will you counsel them?
Sir, we will have to first counsel her that she might require a prolonged admission and strict monitoring, sir, throughout her pregnancy, sir, and that it is a high-risk pregnancy with poor both maternal and fetal outcomes, sir. And we will have to also modify her pulmonary hypertension medicine, sir.
Okay. Yeah. You won't tell
The
them.
age
Look,
of the patient, sir?
she is about 30 years. Okay, so fair enough. One thing you should not tell them is, look, I told you not to become pregnant and you don't obey me. That's the wrong time to say.
It's the wrong time, sir.
Or don't come to me. Don't come to me for treatment. You are not following my orders. Don't come to me for treatment. Is that what you're going to tell them?
No, sir.
That's definitely not on, because now she has become pregnant. You have to support her and you have to go through the pregnancy with her. So we have to deal with her sympathetically and talk to them. And it's not the time to frighten them also. Okay? No point in frightening them and making her more nervous and anxious. So you have to warn them that it's not easy, but at the same time, you must be optimistic. Okay? So
Yes.
it's a cautious optimism is what, in order to maintain the courage of the patient. We don't want her to become depressed and give up. No, we need her cooperation for the rest of the pregnancy and treatment. That's most important. The second thing is, how do you explain the prognosis? You said bad prognosis. How are you going to tell that to them? You're going to die. Your child may die. Is that what you're going to tell? How will you counsel them? Anybody? Well, you're a consultant. You have to handle this. You can't tell somebody else to talk. No answers? Well, before you talk to prognosis, you must know what the prognosis is. Unless you know the prognosis, how will you tell the patient? So you tell me what is the pregnancy. You can't say high risk. You have to tell me percentage. What is the percentage risk to the mother? What is the percentage risk to the baby? Come on, quick, anybody. What's the percentage risk to mother? Risk to life, risk for complication. Three things you will have to know. Risk to mother's life, risk of a complication but not fatal, and thirdly, risk of fetal loss. Okay, I think I'll tell you. Earlier, it used to be said that pregnancy, all textbooks, if you read, will say pregnancy and pulmonary hypertension carries a very high risk. In fact, there are many articles which say that mortality is somewhere between 25 to 50%. And more recent textbooks say around 15 to 25%. That is 1 in 4 mothers die. And it's also said about 30 to 40% of babies miscarry. So mothers lost about 15 to 25% and baby lost about 30 to 40% in severe pulmonary arterial hypertension. The loss is even higher if it is Eisenmenger syndrome, because their pulmonary hypertension along with hypoxia. Now hypoxia is very bad for the baby, because even otherwise the baby's PO2 is Is the fetus PO2 100? What is the PO2 in the fetus? The highest PO2 in the fetus, what does it achieve? Do you know? Anybody? Hey, you guys are supposed to know fetal circulation. You know, just the process of transfer from mother through the placenta, the oxygen level dips. And the placental, the fetal saturation and oxygen supply is only at about 80 to 85% of normal. If mother is 100%, the fetus level is only about around 85%. Now, if mother herself is 75 to 80%, then the fetal oxygen level will be only around 40 to 50. And that's incompatible with fetal survival. Therefore, pulmonary hypertension, very bad prognosis for the baby. And if it is pulmonary hypertension with Eisenmenger, it's even worse. Okay? So this is the conventional thought. But more recently, data has been shown that with careful management, the prognosis is not all that bad. And we must be aware of all recent publications. This is one publication in 2017. After that, there have been few more publications on follow-up. This is a French paper, 20 patients with severe pulmonary arterial hypertension, 26 pregnancies, 18 were delivered successfully. Now that's not bad. It's not 30%, about 8 fetus were lost out of 26. Some slightly less than 20, around 25%. Okay. Now, mortality in mother was only about 5%. It was not 15 to 25%, it was 5% mortality. And obstetrical events were down from around expected 50% to about 25%. That is a complication and which requires management. Therefore, current data indicate that the prognosis is not all that bad. It has improved. It's still very high. It's still 5% mortality for a delivery is quite high for mother. And 25% complications rate with 8 out of 26 babies lost is still high. But still it is better than what was described earlier. Therefore, the first thing to tell the mother is, yes, earlier the prognosis was very bad. But now with current management, the prognosis has improved. There's still a high risk of fetal events, but mother's prognosis has definitely improved. And as always, most complications occur in the end of second trimester or early postpartum period. Why is that?
Sir, because that is a time of maximum fluid overload that can happen, sir. Yes. Because of
fluid overload and
contraction and heart failure also, sir. That
yes.
is a...
And postpartum period is a high stress period because severe volume changes, the uterine contraction, blood loss, and transfer of blood volume from the uterus to the maternal circulation, a drop in hemoglobin, possibility of embolism from the sinusoids, pulmonary embolism, so on. So many things can go wrong in the postpartum period. So that's a dangerous period. And therefore, pregnancy, if managed properly, the mortality mother can be brought down to 5%. And this is what it involves. Mortality, of course, depends upon the functional class. This girl was in class 2, this lady, yes, class 2. Somebody class 3 or class 4, we definitely don't allow them to go to term. And if the pulmonary hypertension severity, depending on whether there is right heart failure and tricuspid incompetence and all that, we need a very high risk, planned, multidisciplinary care. The obstetrician, the cardiologist, the pulmonologist, anesthetist, everybody needs to work together. You know, all the precautions which we advise to PAH patients, avoid respiratory infections, take vaccines, to avoid flu and all that, avoid exertion, don't go to high altitude and so on. All that are very, very important. Among drugs, this lady is on bosentan and sildenafil. ERA is considered teratogenic, so bosentan cannot be given. Whereas sildenafil and prostanoids are considered safe. Do you know any oral prostanoids now available?
Iloprost, sir.
Innoprost is not oral. I'm asking orally administered. Throughout pregnancy, you can't give inhaled. Inhaled is we don't have it in India. And you cannot give IV prostanoids continuously through pregnancy. Oral prostacyclin analog is Selexipag. Okay. And of course, as soon as about 36 weeks are over, depending on mother and fetus, elective delivery is always better. Planned delivery is always better. Now, the greatest risk in these patients, there are two things. One, if there is an acute insult to the body and the PVR goes up, that can happen in just pain, shock, hypovolemia, some anesthetic medications. So acute rise in PVR. And equally dangerous is a fall in SVR. Sudden systemic vasodilatation due to pain, due to some anesthetic agents. So like a vasovagal syncopal episode the patient has. So this fall in SVR is even more dangerous because pulmonary hypertension will not allow the RV to increase the output. And fall in SVR, the arterial pressure will drop and coronary cerebral perfusion will drop. So the patient will collapse. So it's very important that in delivery or in cesarean section, careful monitoring of volume, so the vascular resistances, acidosis, everything is monitored. With very careful multidisciplinary care, you can bring a lady out of pregnancy. And therefore, although we don't like to do it, it is possible. So you must have a cautious optimism. That's what you should counsel right at the beginning. Okay, pregnancy has happened. Now we'll try and manage. We'll have together. We need your cooperation. You need to become frequent visits and even long admissions, and we'll take care of it. Okay, that's the answer I want. Clear or not?
Yes, sir.
Okay. Kavita, tell me when to stop. Hello? Okay. Kavita was not saying anything to one more. Quickly, anybody can answer this question? 18-year-old male, asymptomatic, acyanotic, referred for a heart murmur. This is the cath data. Have you been through the cath lab? Anybody? Varun or Anushri or whoever wants to answer. What does the saturation data show? What does the pressure data show? Quickly.
The saturation data is showing a step up at the right atrium level, sir.
Okay, large step up at the atrial level. Okay, good. The shunt is likely to be large or small?
Large shunt, sir.
Looks okay. Because venous saturation is 72 and the pulmonary artery
72 and going to 85.
72 to 85, 13% step up. So shunt
Yes,
is
sir.
likely to be large. Okay, good. And what does the hemodynamic data show?
Sir, hemodynamics.
Quick. Before Kavita comes back and shuts us off. Anybody?
Is
Okay,
mild
somebody-
pH, sir.
Okay, mild pH. 30 is not pH. 30, okay, for 22.
Mean of 22, sir.
Yeah, okay. Very mild PAH. Okay. So everybody agree. Somebody has said restrictive ASD in the chat box. Restrictive ASD, large shunt? What are you talking of? Everybody agreed that it's a large
It
shunt.
is a large
72.
shunt, sir.
72. We said a large shunt, and how can it be restrictive ASD? So what's your diagnosis, Anushri?
Sir, a large ASD, sir, with the left to right shunt with mild
Okay,
pulmonary
large.
hypertension.
Okay. What's unusual for ASD?
Pulmonary pressures are not high, sir.
No. That's okay. How many? 18 years ASD rarely causes pulmonary hypertension. How many adults we do, they don't have pulmonary hypertension. What is unusual in the pressure data?
Left atrial pressure is also PCW.
Left atrial pressure is 11, normal, no?
Normal, sir.
Then what is unusual? Anybody, come on. What is unusual pressure data? What is RA pressure?
Normal, sir. RA pressure is normal. 5.
RA pressure is normal. LA pressure is also normal. But does it suggest an ASD? If there is a large ASD, what will happen? Large ASD, what will happen to RA pressure and LA pressure?
It should be equal, sir. At least equal.
Is it equal here?
No, sir.
Then what is the answer? Then how can it be ASD?
Sir, is it PAPVC, sir?
No, you can't ask me question. You have to tell the answer.
It could be PAPVC.
Okay, good. So there is a large step up in the atrium with unequal LA and RA pressure. So there must be a left to right shunt at the atrial level without a ASD. So the diagnosis is yes, possible PAPVC with intact atrial septum. You must say that. Partial anomalous pulmonary venous connection with intact atrial septum. What are the other causes of step up in the atrial level?
Sir, rupture sinus of Valsalva in RA, sir.
Okay. Can it be rupture sinus of Valsalva?
No, sir, because then thus desaturation will be for all the chambers, sir.
No. What? I didn't understand what you're saying. Can this be ruptured sinus of Valsalva? I'm asking. What is the clinical picture of a ruptured sinus of Valsalva?
Sir, acute dyspnea and chest pain.
This fellow is asymptomatic.
Yes, sir.
And secondly, very little PAH, very mild PAH. RSO always has PAH. RSO is not likely. Any other cause of atrial shunt you know of? Coronary AV fistula?
Coronary fistula.
Okay. So that's important. Don't diagnose large ASD here. The clue is large left to right shunt with unequal RA and LA pressure. Therefore, ASD is unlikely. It can be a partial anomalous pulmonary venous connection. Coronary AV fistula is possible, but coronary AV fistula rarely causes that much of step up. Usually the shunt is smaller. Why can't it be total anomalous pulmonary venous connection?
Sir, there is no cyanosis, sir. Aorta is 97. Femoral is 90.
Don't say cyanosis. What is the correct term? Cyanosis is a clinical sign. Clinical onset. In cath, what do you say?
Desaturation.
Desaturation. Don't use wrong terms. No? It creates a bad impression. Okay? So this is likely to be a partial anomalous pulmonary venous connection with intact atrial septum.
Yes,
right?
Sir. Yes, sir.
Okay, Kavita?
Yes, sir.
Are we out of time?
No. We can continue, doctor.
Okay, just one more slide and I'm done.
Sure, done. Okay, sir. Okay.
One more slide. Okay, sorry, wait. This is the last slide. Okay. Right, can everybody see it? 24-year-old lady, quite symptomatic. Class 3 dyspnea and in heart failure, frank heart failure. And this is the cath data. Quick. Very sick patient, obviously. And this is the cath data. Also has a large step up in the atrial level. I'm giving you a hint also. You got a large step up at the atrial level. You got pulmonary hypertension. I gave you that hint also. And I'm also giving you a hint, both the RA and LA pressures are equal.
So ASD with left to right shunt, sir.
Yes, large left to right shunt.
Large left to right. Both atrial pressures are equal. And moderate pulmonary hypertension, 70.
46 is not moderate. 46 mean is severe. Diagnosis. I told you RSOV is very sick. Can this be RSOV?
Yes, sir. It could be RSOV into RA, sir.
Everybody agrees? Does anybody disagree? I disagree. Anybody else? What is against RSOV? RSOV is the iota to RA shunt. What will you see in the aortic pressure?
Yeah, it will be. The systolic should be lower than LV systolic, sir.
Oh, come on. When you have a large shunt from aorta to RA, what will the aortic pressure be like? Won't it have a wide pulse pressure?
Yes, sir.
Won't it have low diastolic pressure?
Okay, sir.
Won't the pulse be hyperdynamic?
Yes, sir. Wide
Then?
pulse.
Huh?
Yes, sir.
No, this cannot be RSOV. Don't say it is RSOV. Even though the patient is very sick, there is no evidence of aortic runoff. There is no wide pulse pressure. The diastolic aortic pressure is normal. Does anybody else? So this is not RSOV. Then why is this patient with ASD in heart failure? And what are the causes of heart failure in ASD?
Atrial fibrillation.
Atrial fibrillation. She is not in
atrial arrhythmias.
Yeah, she is not in atrial arrhythmia. You see the A and B wave pressure are clearly given. So she is not in atrial arrhythmia. What else? Elderly patient with RV dysfunction. And this lady is not elderly. Eisenmenger syndrome. This lady is not Eisenmenger syndrome. Anybody else can think of something? Somebody has said cleft mitral valve. Who said that? Emily. Yes, cleft mitral valve will cause what? But you've got mitral regurgitation, isn't it? Okay. Does the LA pressure look like mitral regurgitation? Does the LA pressure look like mitral regurgitation?
Again, mitral regurgitation pulse pressure with MR, sir.
Mitral regurgitation should produce large V waves. So it is not there. And somebody said myocardial disease. Varun says myocardial disease. Do you think myocardial disease is there with LVEDP of 9? Varun, is it possible? LVEDP 9 millimeters and myocardial disease. Then somebody says infective endocarditis. Come on, don't bring in a new diagnosis.
Development of systemic hypertension in these patients can also precipitate failure.
Does this lady have pulmonary systemic hypertension?
No, sir.
Huh?
No, sir.
Then infective endocarditis don't bring in here because ASD patients are not prone to infective endocarditis. So the causes of heart failure in ASD, you told me old age, atrial fibrillation, you're told LV dysfunction due to myocardial disease, you're told mitral regurgitation. You're told so many things, but one important thing you still haven't told me. And that is what this patient has. Look at the LA pressure and the LV pressure carefully. What does it show? The unusual feature is this lady with 24 years age is having heart failure and severe pulmonary arterial hypertension. And you find normal, anybody want to comment on that? LA pressure and LV pressure? It's not mitral incompetence, definitely, because V wave is not big. Normally, A wave should be equal to EDP, isn't it? Because A pumps blood into the ventricle and raises the EDP. So A and EDP are always equal in the normal heart, the normal filling pattern. Here, A wave is 3 millimeters bigger than the EDP. It's a very small difference. But in a patient with a large atrial shunt and severe heart failure, severe pulmonary hypertension in a patient living in India, what should be the diagnosis?
MS.
MS.
Mitral stenosis.
ASD stenosis. And what is the likely severity of mitral stenosis? It's hard to judge from this because in a case of ASD with mitral stenosis, what happens is the LA gets decompressed through the ASD into RA. And therefore, you don't hear the mid-diastolic rumble across the mitral valve. You also don't get a large gradient across the mitral valve. The gradients are often very, very small. Just 2 millimeters, 3 millimeters, that's all. So you find a difference of only 3 millimeters here, A wave of 12 and EDP of 9. If you take mean pressure, 11 and 9, only 2 millimeters difference. And here 3 millimeters. But because of this clinical picture, one must suspect this lady has associated mitral stenosis. And that mitral stenosis must be significant because it's causing such a large shunt and such a severe degree of pulmonary hypertension, because we don't expect that in a 24-year-old lady. Therefore, I expect mitral stenosis to be moderate to severe. And because of the ASD, the mitral stenosis is being underestimated. It is being masked. The murmur is being masked. The gradient is being masked by the ASD. So what is the other question? What other test would you like to do or see now? Which is the best way of diagnosing mitral? Huh? Hello?
2D
yes? Echo. Echo is a much better way of assessing mitral valve stenosis in the presence of an atrial septal defect. 2D echo is the best way of assessing mitral stenosis in the presence of a large atrial septal defect. Cath is not a good way. Cath can only give you suspicion, but it can. Therefore, the likely diagnosis, mitral stenosis, severe. And which other test would I like to do? I would like to go back and see the 2-dimensional echo carefully. Okay?
Okay, sir.
Okay, I'll stop here. I think we're already over time and we'll stop here. Now, you got to learn from every case that you're seeing in your clinic.
Recording stopped.
Right? So I hope